shows straight type thyroid dedicated implant for the electrode. Compared with the electrode in the liver, thyroid electrode is short for easy control because thyroid gland is a superficial organ and thin to minimize thyroid injury. And the tip is sharper, much sharper than the liver. And we can use various size active tips according to the size and volume of target node. This table shows the size of activity and the proper RF power. We recommend this RF power, and I personally prefer the 7mm activity to treat thyroid nodules less than 3 centimeters, and more than 4 centimeters, I prefer 1 centimeter activity. Let me introduce 3 innovative devices will be covered by other doctors. This is a bipolar electrode. In bipolar electrode, activity and grounding pads are put together at the tip of electrode. Therefore, ground pads are not necessary in this electrode. Bipolar electrode is safe for pregnant women and patients with pacemaker, and it is less painful than monopolar. This paper will compare the bipolar and monopolar electrodes. You can see the three-point simultaneous ovulation. The size of ovulation shows the bipolar electrode is very similar to that of 7mm monopolar electrode. However, what about the shape of ovulation zone? Bipolar shows more ellipsoidal in shape, but monopolar shows more round shape ovulation zone. We use this bipolar electrode for a patient with cardiac problem. Here, this patient has 2 primary thyroid cancers, but inoperable status due to cardiac problem that caused the cerebral infarction. So we use the bipolar electrode for this patient. You can see the moving shunt during ovulation, like this. And finally, you can see the marginal venous staining, like this. And this kind of ultrasound feature can prevent marginal venous. The second one is the 19 gauge. 4mm or 5mm activity, 19 gauge. Compared with the 18 gauge, 19 gauge is easy to puncture small lymph node or parasite tumor. And these small active tips can minimize thermal injury. And the precise ablation is possible. Here is a recurrent tumor. I treated this tumor 4mm activity. In this image, lidocaine injection to control pain, and then puncture the 4 millimeter at the tip. You can see the very precise ablation. Ablation zone does not cause surrounding structure damage, sonar damage. Third one is adjustable electrode. This adjustable electrode can control the size of activity from 5 millimeter to 1.5 centimeter. So when you treat large benign thyroid nodule, center is managed by 1.5 centimeter activity that can induce large and fast ablation zone. At the margin of the nodule, we can use 5 millimeter activity. It is precise and treat the very small ablation zone, and the marginal venous ablation is possible by using this small electrode. So this article suggested adjustable electrode has advantages: precise targeting of nodule and deliver optimal RF energy and minimize complication and minimize pain. Let's move on to the techniques. I will talk about 3 conventional and 3 advanced techniques. This 2017 Korean guideline suggests 3 standard techniques. First one is heavy thyroid lidocaine injection to control pain, and transseismic and moving shot techniques. This image shows a perithyroid lidocaine injection. You can see the perithyroid lidocaine injection and the thyroid capsule, like this, and then treat the thyroid nodule by RF ablation. There is no sensory fiber inside the normal thyroid gland, but abundant in thyroid capsule. That is why we recommend perithyroid lidocaine injection to control pain. This image shows transseismic approach method. Transseismic approach method has several advantages over other methods. This ultrasound image, transverse image, shows the relationship of thyroid nodule, entire length of electrode, and the possible location of the laryngeal lobe is clear in this transverse image when you use transseismic approach method. And as you can see, the electrode pass enough normal thyroid parenchyma that can prevent leak of oblated hot fluid from nodule to outside the thyroid gland, and enough normal thyroid can prevent electrode moving when the patient swallow or talk. And finally, most important thing is vascular ablation technique is possible at isthmic area. In the isthmus, there are a lot of feeding artery and draining veins. So, before ablation of thyroid nodule, please ablate the vessels around the isthmic area. when you use transseismic approach method. And then third one is moving technique. During moving jet technique, we should monitor the entire length of electrode. Ablation starts posterior aspect of the nodule, and then we continuously pull the electrode, and then electrode tip target untreated area like this. This is the moving shot technique. And let's move on to the advanced techniques. First one is a hydrodissection technique. In asymmetrical center, we use 21 gauge C-band needle and 3-way connecting 1% lidocaine and 5% dextrose water like this. In this article, we proposed 4 types of hydrodissection techniques. First one is anterolateral hydrodissection. Here you can see the hydrodissection needle, anterior surface of the thyroid gland, and continuously inject the fluid. The fluid is shifted to lateral and even posterior aspect. We call it anterolateral hydrodissection. Using this technique, we can successfully treat the marginal veins like this. And the posterior approach, I use this approach method to treat the parathyroid tumor. You can see the needle approach at posterior aspect and inject large amount of hydrodissection like this. Third one is a pretracheal approach. This hydrodissection technique separates the ischemic area. Here is PTMC and the trachea to prevent tracheal damage during treatment of the ischemic area. And the last one is the danger triangle approach. The needle directly puncture the danger triangle area and inject fluid like this. This hydrodissection can separate the tumor and esophagus and trachea. In terms of material of hydrodissection, this article suggests 5% dextrose water is the best. The experimental study shows 5% dextrose water achieved the most lower damage to liver, diaphragm, and lung. In addition, 5% dextrose water is non-ionic compared with the normal saline and isomorphic compared with pure water. So they recommend 5% dextrose water is the best fluid for radiofrequency ablation. Therefore, our guideline also suggests 5% dextrose water is preferred to normal saline for hydrodissection. Let's move on to the vascular ablation. This technique is useful for highly vascular thyroid nodule. Let me show this table. This is a 5-year follow-up clinical outcome of RF ablation of benign thyroid nodule. What about the volume reduction? All studies achieved excellent volume reduction. However, At 5-year follow-up, the thing is regrowth of the nodule, and the delayed surgery is caused by regrowth up to 11% in this study. So at long-term follow-up, the thing is regrowth and followed by surgery. Therefore, this is a 10-year follow-up study from Samsung Medical Center. This study also showed regrowth rate is very high, 24%. And among the patients, 22 patients received the surgery. And finally, around 20% patients showed malignancy at pathologic result. Therefore, control of regrowth is a very important factor at longer follow-up result. Our team published this paper in 2017. Vascular ablation technique is important. There are two types of technique: artery first ablation and venous ablation technique can minimize marginal tumor recurrence. Here is very hypervascular, especially marginal vein is prominent in this nodule. After venous ablation, you can see the air bubbles inside the marginal vein, like this, echogenic. This finding suggests this nodule is completely ablated. Therefore, 2 years later, there is no vascularity inside the nodule. What about the size? It's markedly decreased. So recently, our team published this technique, vascular ablation technique combined with anterolateral hydrodissection. As I introduced, this image shows anterolateral hydrodissection and marginal venous ablation, like this. During anterolateral hydrodissection, before ablation of thyroid nodule, we recommend ablation of isthmic area, especially focusing on artery and even veins, that can reduce arterial supply to nodule and reduce heat sink effect. Therefore, nodule ablation is easy. Second stage is ablation of central area. Ablation of center of nodule is easier than marginal ablation. Therefore, sometimes we use 1.5 centimeter adjustable electrode for center ablation. Using this large adjustable electrode, ablation is fast and large. Finally, large amount of hydrodissection is done like this, and then remaining margin of nodule is treated by using small electrode, 0.5 centimeter. This marginal venous ablation with continuous hydrodissection can achieve complete marginal venous ablation, and the pain is nearly absent, And what about the damage of surrounding structure? It's prevented by this hydrodissection. So, anterolateral hydrodissection, combination with the artery first and venous ablation using adjustable inlet. Center is treated by 1.5 centimeter. Margin is ablated by 5 millimeter, very small. It is very useful. And finally, let me introduce tracheal stent assisted ablation. We applied this technique to thyroid goiter with acute dyspnea patient. And then we reported tracheal stentings and radiofrequency for multinodular goiter with airway compression. This patient visited our emergency room because of huge goiter, compressed trachea like this. We immediately applied the tracheal stent and then treat bilateral goiter. What about the neck bulging? It's much improved. And then we applied this technique, tracheal stent assisted RF ablation to recurrent thyroid cancers invading airway. Let me introduce this concept. Here, recurrent cancer grow inside the tracheal lumen. The tracheal stent pushes the tumor outside the trachea like this, and then we can treat this tumor. After total thyroidectomy, we can see the small remnant tumor at the tracheal margin. As time goes, the tumor grows inside the tracheal lumen, like this. The patient complained of hemoptysis at that time. Ultrasound shows hypervascular intratracheal tumor. Here, we apply tracheal stent. After tracheal stent applied, you can see the tracheal stent inside the tracheal lumen, and the tumor is pushed outside the trachea like this, and we can see the feeding artery here. So we ablate the tumor and the feeding artery together. It is a single session RF ablation. This is the CT scan before ablation, 4 months, 16, 40 months after RF ablation, there was no recurrence. What about the PET-CT? Uptake was completely disappeared. So tracheal stent assisted RF ablation is effective in both thyroid goiter and trachea involving recurrent thyroid cancer. So today I introduced thyroid dedicated devices will be covered by Professor Deandria and Dwi. And the techniques I introduced three conventional techniques and 3 advanced techniques. Please remember the anterolateral hydrodissection with venous ablation technique. It can reduce marginal growth in the long-term follow-up period. Thank you very much.
When you talk about vascular ablation, Are you worried about bleeding? Do you directly put the needle into the blood vessel?
Directly puncture the vein and then stay. The bubble spread along the vein and then stop the flow. That means vein is completely destroyed by hot elbow.